Welcome everyone. Thank you for joining us for today's webinar. I'm Swapnil Saxena and I work at the National Institute of Urban Affairs, and I'm a part of the city's program management unit. So as you all know, today's webinar is a discussion on rethinking integrated urban development through the lens of public health. First of all, we are really very sincerely thankful to our speakers for taking out the time and agreeing to be with us on the panel today. So I would like to briefly introduce our panelists with all of you. Our first panelist for the day is Professor Prabhakaran. He is a cardiologist and an epidemiologist and an internationally renowned researcher, and is the currently he is the Vice President of Research and Policy at the Public Health Foundation of India. He is also the Executive Director of Center for Chronic Disease Control in New Delhi. And in addition to this, he's also professor at the London School of Hygiene and Tropical Medicine. Our second speaker for the day is Dr. Pratap Kumar. He is a clinician, a neuroscientist, a health economist, and an entrepreneur, and he works at the interface of health sciences and healthcare markets. So Pratap founded Health eNet Limited in 2012. This is basically a social enterprise working to improve access and quality of primary healthcare in low resource settings. Pratap is also a senior lecturer in Strathmore University Business School in Nairobi. And in addition to this, Pratap is also the global mentor for the Smart City of Kochi, where he mentors the city's project team. Our third speaker is Ms. Binya Joseph. Binya currently leads the ICT project implementation in Kochi Smart City, and she's also the project in charge for the city's project in Kochi. The project team based out of Kochi is implementing e-health solutions in primary, secondary, and tertiary urban healthcare centers through an interconnected healthcare network. Prior to this, Binya has extensive experience in software design and development. The webinar would be moderated by Dr. Uma Mahesh from NIUA. He is the chair of the Urban Resilience Unit at NIUA and is a risk resilience professional. Some of you who had joined us for the first webinar know that he was also a speaker at the launch of our webinar series. Dr. Mahesh has over 15 years of experience in developing risk reduction strategies, climate change analysis, hazard modeling, and institutional analysis. So we are delighted to have all of you on the panel. Without further ado, I would like to ask Dr. Mahesh to commence the discussion. Just a little housekeeping rule for all the participants. If you have any questions that emerge during the presentations, we would request you to type them in the chat box in the Q&A section. It is there on the control panel on the right, and we will have time for questions at the end. So thank you. I would give it over to Mahesh to take the discussion forward.
Thank you, Swapnil. First of all, I would like to thank everyone for taking time and attending this wonderful event, and especially those from the Smart Cities team. In spite of their busy schedule, they have taken time to join us for this particular webinar. As Swapnil mentioned, we have with us a very interesting group of panelists. We have with us a medical professional with a huge amount of experience in healthcare sector in India. We have an entrepreneur with us who has worked around healthcare sector, and we have also a city official who is implementing projects across Kochi in India. So it's a great team of panelists, and the most important thing what we want to discuss is how we look at the current pandemic as it is today, but also as we move forward, what can cities do and what are the options available for city representatives and other stakeholders to take the discussion forward in a more sustainable and resilient manner. Without further ado, I would like to invite Dr. Prabhakaran to start his talk. Dr. Prabhakaran, please.
Thank you to the team for asking me to say a few words. I'm going to take 7 to 8 minutes talking about the public health challenges in urban development. I'm basically going to address one or two questions like what is the link of urbanization to health? What is the evidence that we have so far, at least from India, and what can we do about it? I mean, I'm going to try and answer these three questions as far as possible. So we all know that urbanization is a necessity, and it's happening. You can't prevent it from happening. But the question is, how do you make it smart? How do you develop smart cities? And at the same time, how do we maintain the health of people so that it doesn't come at a very big cost? So as it was said, that cities offer real opportunities for improving health, but developed and managed poorly, resulting in significant impacts on health. And therefore, it produces major public health challenges. The biggest challenge, of course, for India is non-communicable disease. We all know nearly two-thirds of India's death is caused by non-communicable diseases. The five major ones are the cardiovascular disease, cancer, lung diseases, diabetes, and mental health. So when you add injuries in addition, it really is a big number. Infectious diseases actually has been coming down, except for this COVID epidemic recently. Mental health has actually been added to non-communicable diseases, but some people take it up separately. In addition, there are health effects of climate change and air pollution, which I'll talk briefly. And last is accidents and injuries. So while urbanization is a necessity, unplanned and chaotic urbanization is a threat to economic growth and a sustainable development. So let's look at an example of urban design, urban health, and physical activity. Now, we have established a cohort in Delhi and Chennai. This is the population representative cohort. And we have geocoded these cohorts in their households. And we annually do a survey to see, in terms of incidence, are they developing new heart disease, new diabetes, and so on and so forth. These are just cross-sectional data. This is, I think, cohort population in Delhi. And as you can see here, can you see the marker here?
Yeah.
Okay. There's a red circle, and there are a cluster of households here. This is where one of our cohorts reside, and these are people with low physical activity. It is the same cluster of people who have high fasting blood sugar. So see, there's a big correlation between low physical activity and high fasting blood sugar. We have shown this for hypertension too. But you look at the picture, they're very close to a highway, highly clustered houses, no trees, no greenery, virtually no greenery, possibly no walking paths. So these are all major problems of people living in such areas. The second thing is, what is the relationship of park to mental health? That's another kind of research that we did. We looked at all kinds of parks. We looked at the number of parks in a community. We looked at the size of the parks, and we looked at the distance from the parks. So when you look at this, you see people who are living closer to a larger park have lower burden of depression. Now, one might argue these must be rich people who are living closer to a park, and the poor people are living farther away. And so, how do you know that it is the wealth that is the cause of better mental health rather than the park itself? So we adjusted for all that data, variables which can increase the risk of mental health. What emerged was the size of the park is very important. If you have big sized parks, it gives you equity. It's not only the rich who use big parks, the poor also use big parks. The smaller parks are taken away by gated communities or for criminal activities. So big parks make a difference in terms of mental health. And this paper has been highly cited because it's one of the first examples to show clearly how big parks are related to mental health. The second thing we looked at is noise pollution. If you look at the larger circles, the violet or the blue color circles here, they represent the level of blood pressure. The larger the circle, higher the blood pressure. And where can you see higher levels of blood pressure in the population? It is in places where there's a very high level of traffic density. As you come farther away from traffic density, as you can see here, the blood pressure levels are lower, clearly suggesting that we need to do something about noise pollution in our urban communities. The next is we created a walkability index of Delhi based on several parameters that includes congestion, comfort index, safety index, exposure to sunlight, exposure to heat, the road connectivity, the rail connectivity, the metro connectivity, and came up with a walkability index. And as you can see here, high walkability is present only in parts of central Delhi where you have the New Delhi area and the central Delhi area. Most of the other areas, the walkability is extremely poor. The second thing is even within a family, I mean, air pollution is also an important component of urbanization, but even within a family, the exposure to air pollution may differ between husband and wife. Like here is an example of a woman and a man, and you can see here we use personal monitoring to measure air pollution level in this couple, and you find that it's quite low in the man. So this is because of poor ventilation conditions, and therefore we need to look at ventilation as an important component of urbanization. Road safety is another issue. Pedestrians are the most vulnerable road users. Lack of road safety that includes insufficient number of pedestrian crossings, foot overbridges, subways. Most of the footpaths, even if they are there, they're encroached upon, they're dug upon. It's difficult to walk on the roads. These are major issues in the Indian cities, and this actually can improve health quite a bit if we are enable people to walk on the roads, walk on the sidewalks. In terms of land use management in the city of Delhi, there is a mixed land use approach. It has several social benefits and economic benefits, but there are issues in terms of density and connectivity. There is increase in vehicular traffic, noise and air pollution levels, encroachments, inadequate parking facilities, and crime in most neighborhoods of Indian cities, making them unworkable and unhealthy. So what are the solutions that we have at a system level? So sustainable urban development is identified as a key to address issues related to urbanization. And I think the important things that need to be addressed are better housing and sanitation, reducing overcrowding and upgrading slums, safe transport systems, green and public spaces, improving air quality, and promoting physical activity. So sustainable cities have been recognized by all United Nations member states as one of the sustainable development goals, UN goals. Now, one might say that you might have a good environment, but it is the behavior which is the problem. You may tell people to walk, but they don't walk. You may tell people to take the healthy foods, they might not do. But I think for the pathways to health promotion, we require three things. The first thing is we should provide knowledge to people, and that's what most people focus on, so that they say, I know. Then we have to motivate them to say, so that they can say, I want. And you have to give them enough skills so that they can say, I can. And based on this, they can act and perform personally as well as teach others. But for all this, what is required is an enabling environment. So clearly, public health interventions requires both policy interventions and educational interventions, particularly for health belief and behaviors. But we need an enabling environment. I want to emphasize that an enabling environment actually is needed to improve health of our populations. Lastly is the health system. Health systems actually contribute a lot substantially. It is estimated in many parts of the world, close to around 4% of the greenhouse gases are contributed by the health system, but in India it may be close to 10%. So we are working on capacity building of doctors in understanding the role of climate change and air pollution. We are also trying to create technological solution. As you can see here on the right panel, a small point of care device which can do 33 tests, so that the patients don't have to travel back and forth trying to get the report. In one sweep, they can get the reports. In addition, in terms of treatment, we have evaluated several methods of healthcare that largely includes an electronic decision support system, and we have shown that it works at all levels. We have scaled it up to the national level, and in fact, assisted Maldives also in terms of implementing this. So in terms of healthcare, I think urban planners also should decide about healthcare, because there are lots of issues in terms of healthcare. One is patient care, disposal management, the question of sustainable procurement, and several other issues. And so we need to keep into focus primary healthcare in urban location, which is extremely poor currently. We need to harness technology. We need good surveillance system, particularly to use machine learning and artificial intelligence. And we need integrated platforms. We cannot work in silos, look at infectious diseases separately, look at urban engineering separately. We need to work together, and we need to build capacity of physicians for example, in air pollution. So with this, I think this is the last slide, and I'll stop here. Thank you.
Thank you, Dr. Prabhakar, for highlighting the importance of public spaces and some of the physical activities and how it is relevant to non-communicable diseases. Just for the audience, I think it is very important because with the current COVID-19, the vulnerability of people with certain non-communicable diseases, especially the cardiovascular patients, people with diabetes, are highly risk-prone to the pandemic. So, in that regard, it's important that when we look at the short-term impacts, it's also important to understand how the long-term aspects play a key role. People who have questions, please post it in Q&A. We will stop later for the Q&A sessions after all the presenters put forward their view. Without further delay, I request Dr. Pratap to please present his slides. Dr. Pratap.
Thank you. Thank you, Mahesh, Naeem, and team, and Dr. Prabhakaran for the wonderful introduction. So my name is Pratap. As a brief introduction, just to repeat a little bit of what was said earlier, I studied medicine in India a long time ago in Goa Medical College, and since then have been doing a lot of different things that now seems to be coming together in this integration of public health, technology, and possibly even cities. As I was introduced, it was said that I am one of the mentors for the Smart Cities project, specifically Kochi and Binya's group, who will be presenting later. But I'd like to tell you a little bit about how we see public health, especially from the focus using a lens of technology, and how we can use technology to make public health as healthy as possible. So this is an example of this is a picture taken in a Nairobi slum. And slums in Africa are very similar to slums in India or Latin America. And you can see all the public health challenges in this one picture. There's a healthcare facility on the left of the picture. It's working right next to an open sewer with huge amounts of overcrowding and likely poor sanitation and all the other challenges that we have known in public health for more than a couple of centuries now. And so this is the context that we all have to work with. If health doesn't work here in these cities, then it's likely to fail everywhere. And the pandemic is an example of how overcrowding, unhygienic living conditions are contributing to global health challenges. So this is a slide that I don't want to spend too much time on. It just says that the growth in population is mainly happening in cities. So if you see the green area here, these are all the rural areas of the world, and growth has flattened. So most of the population density is growth. So this is a chart of how healthcare in cities. But what's important is looking at these cities. So here are all the rural facilities of Kenya and split by public facilities, private healthcare facilities, and faith-based or non-government organization run facilities. Number is in the public facilities. But you look at urban facilities in the major urban areas, you see the split between public, private, and faith-based changes to a predominance in the private sector. So it's important for urban health, especially, to consider a multi-sector value about rural or really the private sector in any healthcare intervention. So I'm going to give a little bit of a context of how public health medicine, how health systems are likely to change, especially post-pandemic. So here's a split between how medicine has worked historically and public health has worked historically. So like Dr. Prabhakaran was saying, there's been a lot of focus on individual care, whereas public health is mainly around population health. Medicine is very curative and public health is very preventative. Medicine is very facility-based. It mainly works in hospitals and health facilities, whereas public health happens mostly in the community. There's a lot of urban focus. Most facilities are in urban areas. The density of facilities is more in urban areas, whereas public health has so far historically taken a very rural state level system, few work in public. And there's similar challenges that go into the data aspects. The technology has in driven healthcare scanners, low-cost devices, medical technologies, and very little technology has really emerged in public health. And the same with data. Most data in public health happens to be research data, and very little what I call routine data that comes out of routine practice. So the point I want to make here is really about how health systems are likely to change, especially given the pandemic. And what we are seeing much more right now with the pandemic is this link between individual health and population health. So very quickly with the pandemic, we know that population health is going to be based or going to really depend on how we track individuals and how we link individuals to facilities, interventions, and so on. And so there is a very direct link between preventative approaches and curative approaches, between community-based healthcare and facility-based healthcare. And so a lot of our efforts are moving into an urban intersectoral approach where we have to work with public and private sector and other sectors involved in health. And city actors become a major player in the health systems of tomorrow. Are really around what we're seeing around technology around all of us. And there's a lot of innovation in technology and especially devices, which is going to drive some of this change. And third, there's a lot of data that is going to be used using artificial intelligence and machine learning, but this needs to be routine data systems. Data that comes regularly every day, day in and day out, as opposed to specific health projects and research projects that run every few years or in specific places. So I'm going to take a few minutes to show you what this tech and data might look like. I know I might be running out of time. Let me know, Swapnil and Mahesh, if I'm going to be taking too long. So this is the point. These are the points I'm going to make in this slide and the next slide. Right, so when we look at data and technology when it comes to public health, and especially how cities can engage with public health, the approaches are that technology need not be expensive. Right? We need not be implementing systems that typically medicine is used. Even large-scale electronic medical record systems tend to be expensive. And the approach, one of the approaches we have taken to technology and data is to say we have to work with paper. Paper is universally used, easy to use, it's really easily accessible. And it's one of the tools that we have to make data as easily available as possible. The second point is tech should work for all of us, right? So whether we are a 60-year-old nurse who is just getting used to her smartphone or mobile phone, or somebody who is young and is a whiz in using technology, you cannot create barriers within technology. It has to be usable and used by and for all of us, whether it's a community health worker, an ASHA, or a specialist. There shouldn't be an exclusion caused by technology. And the use of technology needs to be targeted. And that's one of the lessons we are seeing from a lot of technology use. If we approach technology by saying, if you put in computers, things will be fine, that's not shown to work. Right? So it's not just enough to say we're going to put in the system and suddenly it will work. We have to be very targeted with the use of technology to say, okay, if we do this, then we can expect this and then that. And if we don't have perspective, So instead of doing the demo now, I can always come back to show how this works. But this is another example of how we use technology in different in Kenya specifically. And this is an example from a partner called Jacaranda Health that uses simple SMS approaches that allows anybody with a mobile phone to be able to connect with the health system. And that is linked with artificial intelligence systems that are relatively easy to deploy at this stage. And it makes it easy for anyone to put in, send in a system, send in an SMS into the health system. The artificial intelligence agent flags important text messages or danger signs, and then takes on, links up with a telemedicine service that allows these SMSs to be acted on by the health system. So again, the message is that it's not about complex technology, it's about making things work with very simple approaches like SMS. This is a slide that shows that how mobile phones, but not smartphones, are very much prevalent. So it's hard to make a smartphone-based system as universally used as possible. And my last slide is about how we make health systems of today work towards a health system of tomorrow. So on the right is a list of initiatives that cities could potentially take to engage and to take ownership of urban health in their jurisdictions. And so I can come back to other things later, and this is my last slide. Thank you, Mahesh, and apologies for running over time.
Thank you, Dr. Pratap. Without further delay, may I request Ms. Dinyam Joseph to please present a case from Kochi.
So, we've already seen what Dr. Pratap and Dr. Prabhakaran had to tell about healthcare. What are the challenges that healthcare poses? Cities have faced, and Dr. Pratap has spoken about how technology can help, but there are also limitations. So I've been asked to talk about what we have done in Kerala, especially as a part of the Smart Cities initiative, and also the larger initiatives that Kerala as a state has implemented. So there are two main initiatives that I want to talk about today, which is being done in Kerala, and the second one being the one which I will brief on because that's where we have played our role as a smart city. So first one is called Adram Mission, which is actually a state initiative, which is directed to about the key word for that is delivering dignified service to the patient. So every patient who comes to a healthcare facility should get a dignified service is the key word. And so what exactly does it do? So we patient-friendly outpatient services, and a lot of primary healthcare centers are there who actually cater to the immediate needs of the lower middle class people. So re-engineering the primary healthcare center. So I was telling e-health is basically a central health information system, one system for the entire state. All the healthcare services, the healthcare centers, will be it the primary, secondary, or tertiary, will be connected using a single database. And it not only has health records, but also basic demographic details of all the citizens in the state of Kerala. So that's a vision. It is not completely rolled out in all the centers, but we are actually, Smart City has helped in giving it a push in at least most of the centers in the Kochi city. So like I said, e-health is centralized health information system and also a central demographic database. So what Kochi Smart City is doing here is we have actually tried to connect, like you can see in the map. So these are the primary centers that we have connected using e-health. And there are also around 30 to 40 secondary level and tertiary level centers, which also will be added to the system, which will make a complete connected system wherein, like if you say a patient or somebody goes to the tertiary healthcare center, and then they finally have to, for whatever reasons, they have to come to a general hospital or maybe a taluk hospital. Their information, their health record, and all the test details is already available in the system. So that's the vision of eHealth, and Smart City is actually implementing this in the state, in the Ernakulam district, and we're just connecting all the major hospitals here. And so what's the outcome that we are trying to achieve is digital healthcare data is centrally available, which is managed and controlled by the state in a data center, which is actually developed and maintained by the state. So there's less risk of data privacy or security concerns that normally arises. And the other is like all this data that is gathered is not just individual health record, but when put together, it aids in disease surveillance, which I know most of you will know that Kerala every year we face, because of the monsoons and our climatic conditions, we face epidemics, and vector-borne diseases are common and waterborne diseases are common. So disease surveillance is also possible with all this data that is collected from different sources. And how does it help an individual? Repeated tests can be avoided and diagnosis can be avoided. Like if I move from a taluk hospital, I've been referred to a general hospital or a medical hospital. My records are already there. My test reports are already there. So I don't have to go through the same again in a different hospitals. And the doctor can access the patient records. His past history is available, so which makes better, helps him in the better diagnosis. And all this data is updated dynamically, and as and when a patient is visiting the hospital, his data is getting updated, and it is also updated by health workers who go for field surveys, they go for household surveys, and they check vitals. So even that gets updated into the system. So it's a completely connected system, which I hope will help us to make decisions in the future, especially when we have, like Dr. Pratap was telling, data is available, but we should know how to use it and derive the best outcomes out of it. And I also want to highlight about some of the key areas where we have actually used technology in the state of Kerala, and especially with respect to COVID response. So we contact tracing. Already many of you would have heard about how Kerala has contained the spread of COVID. So one main point that has helped us is active contact tracing. So this was done by using technology. Like we had people, we had contacted Google and also by mobile networks. So contacts were traced, and that was done in the very beginning, I think early March, and second week of March we started that, and that has actually helped us to contain the spread of COVID positive cases. And another initiative that was done by the team of doctors, especially with the help of technology, was technology, and also I would say the health workers. So they identified the aged parents. Like Kerala has a lot of people working NRIs, and aged parents live alone. So they trace down aged parents, and because they are the vulnerable population, they should not venture out. So they trace down such families, and they provided help and medical supplies were given. They could order medical supplies like oxygen, insulin, and any other medicine that they want could be ordered using an app, and it would be delivered to their step. And not only that, even groceries and vegetables were also delivered in their house so that they don't venture out, because they were the vulnerable populations. And palliative care, already Kerala has home palliative care that is being done by the state. So palliative care patients were also given special attention to make sure that they don't get affected by this situation. And there was a lot of misinformation being passed among the citizens about this COVID in the initial stages. And so the government had a lot of initiatives, and Smart City also had a lot of public messages that were given to citizens to disseminate the right information, to reduce their anxiety, and to give correct information of what's happening around. So I think that has helped a lot. And there's also, since Kerala is also prone to other diseases, monsoons are expected anytime. So we are also prepared for the worst. We already have dengue cases that are coming up. So we are also prepared for that. So disease surveillance is being done, which is done every year, but we're also continuing that. And risk patterns are identified based on past data and also the current data that is being collected to identify if there's any possible conditions of vector-borne disease or waterborne disease. And material and manpower is also being planned so that if any other communicable disease outbreak happens, we should be able to handle that as well. So that's also what we are doing as a city and also as a state. So I think that's it for now. Thank you.
Thank you, Ms. Binya, for taking us through the wonderful initiative which Kochi and the state of Kerala is doing with respect to COVID and use of technology. There are a lot of questions which are coming up, but I'm going to sort them out into two categories: what cities can do in short term and what cities can do in long term. So I'll probably let each of the panelists speak a few sentences about the first question, which is given the current situation, what city administrators and stakeholders can take or do in terms of immediate action, and also with respect to other events. As we are seeing, there is there was a cyclone in Calcutta, and in Assam there is a huge thunderstorm which is going on. Also, with the monsoon hitting the southern coast, there is a possibility of more prevalence of vector-borne diseases and waterborne diseases. In that regard, what can city managers and other city stakeholders can do with respect to also taking care of COVID-19 situation? I'll start with Dr. Pratap, and I'll follow it by the other panelists. Dr. Pratap, your comments, please.
To put this into context, this is something that everybody is thinking about. How do cities take ownership and engage with public health and do this as quickly as possible? And so my approach has been to say there are two main things that cities need to do. One is develop a human resource capacity for dealing with health. Cities typically don't have these human resource capacities to deal directly with healthcare. And this is more and more becoming obvious that cities need to have this human resource to do a few things. One is to coordinate with regional and national level bodies like the Public Health Foundation of India, like international bodies like the WHO. So there needs to be coordination from city level upwards. The second is that we need cities to engage with innovation for health. So these are not solutions that exist. These are new problems that keep coming up. And so the only way cities can respond to challenges like this is to develop a good systematic approach to innovation. How are you going to innovate to address your challenges? Where is this innovation going to come from? How are you going to manage this innovation? How are you going to procure the innovation and technologies and other issues, other resources you need to innovate and solve problems? And so there are two main areas I feel cities should really focus on. One is healthcare human resources. So
I think we have lost Dr. Pratap. Ms. Binya, you want to, please put forward your suggestions, especially what other cities can do, and based on what Kochi has managed to achieve over the last few months.
Yeah, actually, in Kochi and in most of the parts of Kerala, we have. I know already Kerala is very famous for decentralized governance. So, which has also been tried in healthcare, where we actually have decentralized healthcare, meaning like we have, and that's the reason why this Adram mission has also taken much importance, because the tertiary level of healthcare, when we say primary healthcare centers, has been empowered to cater to the larger group. So that should be the first point of access to the citizens, and it's not just in villages; it also works in cities. In fact, in the Kochi city itself, we have around 20 to 25 primary healthcare centers, and there's been a good response in terms of how people actually use it instead of rushing to a big hospital or general hospital for everything. And that has also enabled people to move out of the private sector, is what I feel. Though I don't have really data to back up that, but we've generally seen that shift. So I think cities should start planning in that way, have a different tier of healthcare access to the people.
Dr. Prabhakaran, given your experience, just building on Ms. Binya's point, how do you see, our across the Indian cities, how can we empower the healthcare institutions? And also, there are certain questions about how do we introduce telemedicines? How do people go about, the triage scenario? So, if you could throw some light on the immediate, set of things which cities can start planning around.
So I think with the COVID pandemic, lots of things have changed, and many of the things that are going to come in will stay for much longer than what we think. So as an immediate thing, I think one of the things that need to be strengthened is surveillance. And surveillance, which Kerala is doing it exceedingly well, and that could be a lesson for other cities in the country in terms of what can be done, and particularly they're doing it for COVID. The second issue is, I think close to 30 to 33% of the country's population is urbanized, maybe around 30%. But if we look at non-communicable diseases, nearly 60% to 70% of the non-communicable diseases are the urban locations. And the only way non-communicable disease can be approached or reduced worldwide, this has been shown, is through policy measures, particularly non-personal policy measures and prevention. But if you look at what the government of India has planned, it's planned the health and wellness clinics in all the rural areas, and in the urban locations there is some mention of it. But I think that is what is going to be needed. That is what is we need to strengthen adequately so that we address this issue of prevention of non-communicable disease. And in that, technology plays a major role. And one of the things that we have been actually trialing and working on is to use community health workers and nurses who are empowered with electronic decision support systems in the management of hypertension and diabetes. After a visit to the physician, they really don't have to go back to the physician till maybe a complication arises or some real need arises. So they can be followed up, triaged by these community health workers, and it's been quite successful. That's one area which I think the government is also thinking of, and that is where smart cities can work in improving healthcare. Of course, there are other generic issues which I mentioned in my talk in terms of public transport, in terms of the last mile connectivity, especially we have metros, but people take much more time to get back to their houses. Even if they have to walk, there are no sidewalks. Can we create canopies of trees or tree-lined streets, which have been done in the West? It may be difficult for us to do because of the way we have built our cities, but at least as we are moving forward, creating new areas, extending our cities, can we think of those kind of things and do some kind of simple engineering to improve cities? I mean, there are lots of things. I can go on and on, but in the interest of time and to give others speak, I'm going to stop here.
Thank you, Dr. Prabhakaran. I think it's very helpful. Probably we'll get back to you at the end of the conversation on some of the other key points which you'd like to highlight. Dr. Pratap, we missed out on your suggestions and comments, so please do provide on what are the short-term measures, and especially with the technology, because there are certain questions in terms of how do cities adapt these new technologies quickly, and probably your opinions and thoughts on it will be very helpful.
Yeah, thank you. Sorry, I'm switching from mobile to Wi-Fi and things seem to be going wrong. The two main things that I was trying to say was cities need to invest in specific human resources for dealing with public health, and to deal a process to manage innovation for health, because these challenges are going to keep coming, and to be able to systematically address these challenges time and again, we have to have a very systematic process of managing innovation. Especially for health. And this is a very new area. It's not easy to manage innovation in a complex area like health, but this is a big opportunity as well. With technology specifically, I think what I keep highlighting is it has to be simple. You can't expect a complex health technology where you have to give new devices out to many people and expect all these different people to take on these technologies at a very short time. So the focus on technology adoption has to be essentially appropriate technology. So there is a big literature field around appropriate technology, and my message is, even paper is appropriate technology. And if you can make use of paper systematically, if you can make use of SMS systems well, the abilities for cities to uh, put up systems around simple technologies like paper, SMS, and calls already exist. And you shouldn't be looking at procuring complex health technology at this stage.
Thank you, Dr. Pratap. That's very useful. I think making use of the existing mechanisms and systems which are in place and augmenting it is the key to succeed given the current scenario. Going back to Ms. Binyam, what are the institutional mechanisms? I think you did mention that empowering PHCs and health centers are the key to success in Kerala. What are the institutional mechanisms which are different from other states or other places? And how do you go about the process of ensuring such institutional mechanisms can be, established in other places?
I'd like to quickly share a slide that I have, which I actually prepared to press this point. Yeah. So this is something that I was telling before. So we have, something called sub-centers. It can be called in different names in different places. And then we have primary health centers, and then above that is the, the like major hospitals. So what we've actually done here is, like, every primary healthcare center, it serves a village or a panchayat or a local community. So which has most of the facilities, including maternity services and limited inpatient services. So most of the common communicable diseases or non-communicable diseases can be catered to from the primary healthcare center itself. And then it also responds to the local needs. So and there are also health workers who work closely in touch with these centers. They go to the field, they do the surveillance, they identify what are the health risks, and they actually report it back, and which comes back to one of these centers. So from where it is taken forward based on what is the risk or what is the seriousness of the issue. So I think this is one model which has worked for us, which probably other cities or other states might have to adopt, is what I feel. So and one more thing, like Pratap was telling, so it cannot be just technology alone. Technology has to be something which will aid the human resources. So we at the end we need people. We need the right people and at the right place. But yeah, technology can make their life easy, but technology alone will not provide the solution. We have to plan from a bottom-up approach is definitely required.
Thank you, Ms. Binyam. Going back to Dr. Prabhakaran, I think you've been working a long time trying to integrate, multiple departments, especially health department with also planning department. And your initial presentation also highlighted the importance of urban planning with respect to communicable and non-communicable diseases and their importance in the current scenario. Dr. Prabhakaran, how do you think institutions in India can collaborate and work together? And what is the possible way forward, both in the midterm and also in the long term?
So evidently, this is a very simple question. I mean, everybody says that we have to collaborate, we have to work together, we shouldn't work in silos, we should have multidisciplinarity. But actually doing it is a big problem. But the reason is because of our education system, I suppose. So we should start with the education system. One of the things which I was thinking was, why shouldn't doctors, engineers, and management graduates have a small practicum? They're sent off to a village with a small amount of funds or to an urban location. I'd go and observe the problem and identify a solution. So they come from different fields, they work together, and that's how one could start. I mean, this could be a long-term vision because we need to talk to MCI, the Engineering Council, whoever it is. But I think we should start at that level in terms of looking at theories of change. Somebody asked a question here called, can we do co-creation? Of course, we should do co-creation. And I think under your leadership, you should convene a workshop where there's a co-creation workshop to identify 3 or 4 solutions to the immediate problems that we have. One is, how do we improve surveillance? How do we integrate technologies such as artificial intelligence and machine learning in improving data quality and coming up with for identifying the factors that increase the risk or coming up with solutions. That's number one. Number two is, even in terms of, for example, air pollution estimation, there are different people who do different things. There are four sources of air pollution which people get. One looks at emission inventory, somebody looks at satellite data, somebody looks at monitors, and then there are others who don't even think of how do you adjust for the built environment, what about the greenery, what about the transport. So you require collaboration even within your system. Actually, it is not even going outside the system, but even within your system. So that kind of collaboration is required. So I think these workshops with focused questions to come up with solutions or priority setting for the government would be extremely useful, and we will be very happy to do that. The third thing is capacity building. I think capacity building in a cross-cutting area rather than an area of health or rather than urban planning. We can call it urban health or urban issues or something like that, but it has to be a multidisciplinary team of faculty as well as the participants whose capacity is built, who are made to think differently and work in a different way. That's one. The last is, I think we have a lot of evidence which are lying in silos. Somebody knows some solution for something, somebody else knows. The question is, can we bring it and implement it on scale? I think these are the four questions that we need to think of and work on.
Thank you, Dr. Prabhakaran. Coming back to Dr. Pratap, I think you are already working with smart cities in India, and how do you see the future of smart city projects integrating public health, and what are the current challenges you're facing and in working in smart city projects, or what are the opportunities you're seeing as smart cities progress and by introducing public health into the debate?
Thank you. So to put it really simply, I'd say the pandemic is a great opportunity. So just the fact that there is a pandemic and we all see the effects of the pandemic is probably the best opportunity there has been to restructure the health system, right? And so it has highlighted the gaps, communities and facilities. It has highlighted the gap between public and private facilities, the public systems and healthcare facilities. It has highlighted the gaps between health and other sectors like transport and city planning and urbanization. So, so the biggest force, I think, right now is the next force, I think, is the fact that we are moving towards a shift in public health, moving from a facility-focused approach to a community-focused approach. And cities can do a lot in this regard. Right? Cities can support this bottom-up approach, like what Binya was saying, to say we need to hear citizens' needs, their challenges and their problems, and support their engagement into the health system. So what cities lack right now is with health. And health is run by people like me and Dr. Prabhakaran. We are medical people trained as doctors, and there's a big inertia that comes from the medical community itself. And that is a challenge, right? So it's a challenge for somebody who's outside the healthcare profession, Binya, for example, to engage the health system and say we need to change, because health systems are run by powerful people like doctors. And that, I think, needs a shift. And that shift is going to happen if cities themselves take much more ownership about health, hire the right people that can make this change, and then start engaging the health system as a source of power, right? So cities have tremendous power in shaping our lives. You need to exercise that to affect health as well.
Thank you, Dr. Prabhakaran. We have a few questions from the audience. I already have compiled some of them, and you all the panelists have managed to address most of the questions. But there is one specific question to to Ms. Binya Joseph. What are the key features of the family health centers and how the referral mechanism in Kerala work? And so this is something you'd like to take up.
So actually, all the family health centers, I hope I'm not your note, yeah, are being converted into primary healthcare centers. So that's initiative of the Adram mission. So with much better facilities and even some amount of inpatient service is available. So with respect to referrals, I would say now we are still on pen and paper, but we are hoping that our digital solution will make it more seamless. But if that's a question, I don't know if I answer this question, but that's how referral works for now.
Thank you. And this is for Dr. Prabhakaran. Probably you have answered this in your previous question, but more specifically, One Health is gaining ground, and how does it sync with the public health and integrated urban development? And also some key pointers, especially I think with respect to what cities can expect, in terms of improving their IDSP system, integrated disease surveillance system, which is already in place, and how they can improve it given the current pandemic.
I think with regard to the first question, that is in terms of what was it? Sorry. What is the first question? I can't hear you.
It's on One Health and how it is gaining ground in India.
Sorry, I was focusing on your second and forgot the first one. The One Health is a concept which has been around for quite some time, and it is an important concept. The One Health envisages that the environment in which we live, including the plants, the animals, as well as the human beings, are part of one system, and what impacts one will impact the other. And particular example is this particular zoonotic episode of COVID. It all started with, there is a controversy as to how it started, but one of the things which people have come to the conclusion, it somehow jumped from bats to humans. And therefore, taking steps to avoid such occurrences will help. The other one is the example of Nipah virus in Kerala, where the bats, eating jackfruits and infecting the jackfruits is an example. So clearly, I think if we take precautions, if we take preventive actions in terms of spread of these zoonotic diseases, we will do a lot. Like one specific example is the dengue fever. A lot of people think the dengue mosquito actually breeds in brackish water. That's not true. It breeds in water which is relatively pure and relatively clean. It's a water which is kept in your vessels outside, or it's a water which is poured into a plant, and or there is a small amount of water logging within the veranda or somewhere. That's a place where these mosquitoes breed. So educating people, telling them the importance of maintaining that hygiene is very important. The second thing is we are personally very clean, but we keep our surroundings unclean. This is very true of Indians anywhere in India. And I think one important thing is these the waste that we dispose haphazardly is another area of where cause of poor sanitation and ultimately infection. And this is also part of the One Health program. We have pets living close to us, and these pets can spread these infections. So One Health is an important concept that needs to be universalized. People have to be educated on that, and I think we need to require more work. Antimicrobial resistance is another great example where One Health would be of great help. In fact, there's nearly around 3 to 4% of the deaths in the hospital, and in fact in US it is said around 10% is because of antimicrobial resistance or accidents in the hospital. So clearly there is a big role for One Health. It includes in how does it connect to urban health, the way we build our buildings, the way we build our hospitals, how do we provide laminar air into the system. All those things come into play, and people need to think about it. With regard to the second question, sorry, I forgot to write down. The second one you asked me was on
the IDSP and what IDSP.
I think it is very important that we generate our own data. I'm just coming from the non-communicable diseases field. Like, how did we know that hypertension or high cholesterol or diabetes is a risk factor for heart attacks? It came from a very simple cohort study that was done in the West, in Framingham, in close to Boston, and we got that, and we have been using that. But I'm a strong advocate of getting your own data. One is through the cohorts, which is in the community, but the second is through registries, and IDSP plays a major role here. If we make some disease notifiable, they give us the data, and some of the diseases are really notifiable. But for example, tuberculosis, though in some places is notifiable, it's not notified everywhere. How do we effectively bring about that notification? How do we do the integrated surveillance? And the second thing is, in terms of integrated surveillance, we have had several vertical schemes. So we have had blindness prevention program, we had tuberculosis prevention program, we have cardiovascular diseases prevention. I think we need to get everything under one umbrella. At least there should be horizontal integration at the sub-center level or at the community level where we get data of all these. At a tertiary level, yes, it has to be vertical. It's different the way they maintain registries, but at the local level, there needs to be integration. So make notification of certain diseases compulsory, create a system in which at the level of the community or at the level of sub-center, there is horizontal integration and collection of data across several diseases, be it infectious diseases, maternal and child health, or non-communicable disease. If we do these two things and we have a good place to analyze this data, I think we would have done our job.
Thank you, Dr. Prabhakaran. Dr. Pratap, similarly, two quick questions to you. One, your experience in working with the government sector, especially in terms of co-creation and developing innovation. What has been your experience? And do you want me to say the second question now, or I can wait till you?
Yes, maybe you can wait for until I answer this question. Otherwise, I'll reveal my age and dementia. There are challenges, as you all know, with working with governments, right? So most of the audience in this webinar are from governments, and we understand that there are challenges to working with government. But I think what is really important is to recognize where the strengths of each player. So, for example, no one entity can be doing everything. No one entity can develop the technology for disease surveillance, implement it, get the data, analyze it, and manage it. Right? This is not the job of one organization. And therefore, it's important for governments to be able to recognize who brings what strengths. And that's why managing innovation becomes a very important aspect within the government or within cities. And so in our experience, it's worked really well when we work with the people who have a very specific role to play. The government, for example, in our case, open collection documentation tools to be used. An NGO that is working with healthcare or with these same facilities uses this data to improve to understand where the gaps are and provide the government with the capacity to say, okay, here's the gap, here's what you can do. And a technology company like what we do is to say, okay, here's a technology that's been designed for data to be collected and managed at low cost by the people in the facilities. And so there has to be coming together, and what governments can really do well is manage this or open these doors and allow these collaborations to take place and recognize that this is going to be different people working to their strengths and not one entity doing everything.
Just as a follow-up, the second question is the recent upsurge of technology solutions in health has raised the concerns around data privacy. So how do you build trust around these technology, and what design and policy measures which are being adopted globally to ensure data privacy?
Yeah, so I would come with the approach that health data is not different, right? So we all want all sorts of data to be kept private, whether it's our browsing history, whether it's our bank deals. So I think we should approach it from that perspective. And to that, the reason I bring this up is because we have made significant steps in good practices with data. It starts with consent, right? So we have to obtain that consent that we need. We want to collect this data and we want to use it in a certain way. It's important to start from there. And then once you have people giving you their trust or being talked about or talked with about data and its use, it becomes easier to start saying, okay, this is what we would like to do with this data. This is how this data can be analyzed, researched, and we can gain insights from this data. So I think we need to go back to some of the basic human principles of how we want to use data. Start with principles of and we want this data, this is how we'll use it, and this is how we'll keep it private. That approach, I feel, it doesn't last too long.
Thank you, Dr. Pratap. Just being conscious of time here, and final comments and suggestions, especially to the audience. Ms. Joseph, I'll start with you. Do you have any final comments or suggestions to the audience and the participants in this session?
I just want to add on to what Pratap was telling about data privacy. I also have a question. I think somebody else has also asked it about telemedicine. So with respect to data privacy, so it's, privacy concerns and, our personal identifiable data was always there with the healthcare system. It's not something new that we're sharing. It was there on paper, now it's digital. That's the only difference. So consent, I think, was already there. We didn't mind if all our records and all our data was there lying in some room in the hospital. But now when it's stored on some server, it's just easy to retrieve it. So probably that's that's the concern that is coming. But then I think there are workarounds for that. There's a lot of technology to prevent data loss, so that can be done. I don't think it should. But then yes, along with the technology advancements, our policies also have to be released. The policies, data security policies also have to be in place, because it's not the same. The policy is the same as it was 10 years old, but then technology is not the same. It keeps changing very rapidly. So just with the technology change, our policies also have to be updated frequently. And I also have a question about telemedicine. How Dr. Pratap or Dr. Prabhakaran would see what is the relevance. And I think somebody has asked that questions when we are facing the same situation in our city where telemedicine has actually taken prevalence now. So we'd like to know your views on that and how we can go ahead in a uniform solution for at least a state or a city or a country.
Dr. Prabhakaran, probably answering Ms. Dinya, and also your final comments and suggestions to the audience. Dr. Prabhakaran, you're on mute. Can you please switch on your microphone?
With regard to telemedicine, I said it is here to stay, but I think the concerns are not misplaced. One concern is about the privacy, data privacy. I think we should ensure that the full data should be available only to the patient and to the doctor as it is now. But in terms of storage, the data should be anonymized and encrypted and stored, so that when you do a aggregate analysis, you just get the anonymized data. Second is, I think the patient should be informed, and in a way we obtain informed consent for research. We should obtain consent in terms of their storage. They should be informed that their data is getting stored. Second, I think, is we have to create standards of care. And that's where I think decision support systems are very helpful. In the sense, if a patient comes with a headache or a fever, the doctor asks a question and just enters it into a few questions enters into the tablet or the mobile phone, and through an algorithm, it gives out the diagnosis and gives out recommendations for treatment. While that, many doctors may think that it curtails autonomy, but it's actually quite helpful, so that they don't get into litigations, and there is a most evidence-based advice that would be available. The third is in terms of optimization of the strength of the signals and so on. That's another area, because if it frequently breaks, then it could be a problem. Fourth issue is, how do we address the people with poor education, people who are poor, who do not have access to these systems, and that's where you need innovations in terms of having some, like the Kutumbashri in Kerala or the Sakis, you have somebody to ask those questions and make those entries. I think if we use telemedicine as a tool carefully, it will be a very, very useful tool. But if we use it very casually, it can land up in problems. Then, in terms of the second question that you asked, is in terms of the vision, that what we should do. I think whatever we plan, we should, in urban planning, whatever we should plan, we should not plan for 10 years hence or 15 years hence, because by the time we implement it, we are actually on to the next level. I mean, I have seen in Delhi the flyovers being built and the number of roads being expanded, but by the time they're built, we have enough vehicles to occupy that and cause a jam. So I think we need to plan for 25, 30 years in terms of these smart cities. That is the most important thing. The second thing is, I think we should learn from the West. If you look at urbanization, why is urbanization not such a major problem in the West? It took nearly 200 years from Industrial Revolution to have this urban conglomerates in the West, and they did it in a very, very well planned way. Be it Chicago or London or whatever they do, they've had a plan, and to get to the current level, they took almost 200 years. But we are trying to do it within 50 years or 60 years, and we have several issues. We are doing it in a very chaotic way. So there, we require to do it in a very, very planned way. And that's where I think integrated platforms are essential. The integrated platforms should include the urban health engineering sector, the urban planners, the people from the health sector, management sector, and even the community. I mean, the community voice is never heard. We should have people from the community to advise this. I think this at a high level would be my advice.
Thank you, Dr. Prabhakaran. Dr. Pratap, probably your answer to Ms. Joseph, and also to your final remark and suggestions to the participants.
Yeah, so I have probably a lot to say about telemedicine, because I am, I research this and I implement telemedicine solutions, and we think a lot about how we can make telemedicine as useful as possible. And we just put out a publication. The preprint is available online, and I've shared the link to the answer as an answer to the question that came in. And the fundamental issue with telemedicine is that it's not just one thing. Asking a question to a doctor asking a question to somebody else. It's about sharing an image and getting a response. It's about sharing the test information and getting an automated response. There are a number of things that come under telemedicine, and it's difficult to say, is telemedicine wonderful? Because there are different aspects, and each type of telemedicine works differently. And some parts don't work very well in a setting like in Kerala or in India, and other parts work really well in a setting like Kenya, for example. So we have to get some nuance into the discussion around telemedicine. And so one of the things that we do in Kenya is, when we share information about a patient, we don't even share the last name and identifiable details of the patient with the doctor. The doctor needs to know that this is the patient that they're dealing with. The first name is there, the age is there, the sex is there. There's no further need for date of birth, the address, phone number, or any of these details. And so what do you want to share becomes a very important part of telemedicine. And who do you want to share it with? When does that information come to you? In what format? And so it's to send prescriptions to patients. And this removes the need for downloading applications, downloading software. All you need is get a mobile phone, and you get an SMS with a link in it. You can share that SMS with your family or relation who has access to a smartphone that can download the actual PDF. So it has to be thought through quite carefully about how you share information, to whom, in what format, how much information is there. And so there is So the summary is that we're just entering this era of telemedicine. We have done very little of it at scale. There's a lot of lessons to be learned, and we need to do this systematically. So, I'm going to stop here.
Thank you, Dr. Pratap. Just adding to the conversation, I think there is something called National Data Stack, which even the Prime Minister did talk about, which is called JAM, the Jandan, Aadhaar and Mobile, and how it has helped leapfrog some of the government initiatives and also the public-private partnership, and also helped maintain the data security and privacy. In that similar context, there is also something called as National Urban Stack, which is led by Ministry of Housing and Urban Affairs, supported by National Institute of Urban Affairs. So for the city participants who are interested in knowing more about the National Urban Stacks, please go and visit our website, the smartnet.niua.org. You will get more information, and you can also reach out to us if you need additional information regarding the same. With that, I thank all the participants for taking part and asking very relevant questions, and the panelists for providing implementable solutions based on their vast experience. With that, I'll transfer it to Swapnil. Swapnil, over to you.
Yeah, I would on behalf of NIUA, I would like to thank all the panelists. I think it has been a very insightful discussion, and I'm sure all of us, all the participants, and also us at NIUA have become more context aware, about the importance of integrated management of service delivery, and healthcare, of course, is an important part of it. Um, so thank you to the speakers. I think there are some very important key takeaways in your presentations, very important research findings as well. And hence, I'll get in touch with you after the webinar. With your consent, we would like to share your research as well as your presentations with the participants, and also with those who haven't been able to join, but I'm definitely sure would, be interested in reading up your work. Thank you to everyone who participated, and we got some really interesting questions, very relevant questions. Dr. Mahesh, I would like to thank you for moderating the session for us. And thank you, everyone. See you at the next webinar. Please feel free to get back with any kind of feedback. You can write to us at the city's email address that was shared earlier. Thank you.